Good morning. My name is Karim Chamie, and I'm an assistant professor in the Department of Urology. I'm also the surgical director of the Institute of Urologic Oncology's bladder cancer program here at UCLA. And today we'll be talking about some of the innovative ways we treat patients with bladder cancer and kidney cancer here at UCLA. For those of you joining us through Twitter, make sure you ask your questions through hashtag UCLAMDChat. So if you're watching us live, feel free to ask those questions. Okay. The outline of today's talk, we'll talk about the anatomy of bladder cancer, some statistics, what are some of the risk factors, which type of individuals are likely to develop bladder cancer, staging, some of the existing treatments we have, some of the challenges we've seen in the way we manage patients with bladder cancer, and some of the new innovative ways we're treating patients with bladder cancer here at UCLA. So a little bit about anatomy. First, the urinary system. Now, the urinary system is composed of the kidneys, which are located right over here. Sorry. One on the right and one on the left. The kidney drains the urine through the ureter, which is a long tube that drains down into the bladder. Okay? Now, the kidney is composed of two main parts. You've got the meat of the kidney, which we call the parenchyma. And the types of cancers that occur in the meat of the kidney are called renal cell carcinoma. And then you've got the sink, where the urine actually gets excreted into. That's called the collecting system of the kidney. Each ureter then drains down into the bladder. And here you see the actual openings where the urine drains into. Now, the bladder has various layers. So there's an internal layer of the bladder, and then there's the lamina propria of the bladder, the muscular layer of the bladder, and then the fatty layer of the bladder. So again, here we're talking about the types of kidney cancer and the type of urothelial carcinoma. So the meat of the kidney would be called renal cell carcinoma. The collecting system of the kidney, the ureter, and the bladder would be urothelial carcinoma. That's just basic nomenclature for the rest of the talk today. A little bit about bladder cancer. It's the fourth most common malignancy in the United States. There are nearly 75,000 patients, individuals, Americans who are diagnosed with bladder cancer every year, and over 15,000 of those patients die from bladder cancer on a yearly basis. Now, the incidence of bladder cancer is steadily climbing, and we project by 2020 that bladder cancer will be the third most common cancer in men. What are some of the risk factors? Genetics. Patients who have, or individuals who have a family member with bladder cancer are 2 times as likely to develop bladder cancer. Race, white Americans are more likely to get bladder cancer than African Americans. Men are 3 times more likely to develop bladder cancer than women. And age, bladder cancer is a diagnosis of the elderly, not of the young. And I'll show you some graphs about that later. There are also some infections that can actually promote bladder cancer growth. Some of these infections can be a worm, which is found in Africa and in the Middle East, and some of them can be just chronic urinary tract infections. People have suggested that low fluid consumption may also increase your risk of getting bladder cancer. There are certain types of chemotherapy, and any radiation therapy to the area where the bladder is located would also increase your chance of getting bladder cancer. Of course, I can't talk about bladder cancer without talking about tobacco. Tobacco is the leading cause is the leading cause of bladder cancer incidence in the United States. There's other agents that can also cause bladder cancer, such as dyes and solvents. So people who work with rubber and leather and textile and printing products are more likely. So painters, machinists, mechanics, printers, hairdressers, and truck drivers are all more likely to get it just because of the solvents that are being evaporated in fumes or inhaled. Now here we're talking about bladder cancer incidence. So as you see, patients in their 20s are much less likely to get bladder cancer, but as individuals get older and older and older, they're more likely to get it. So half of people who get diagnosed with bladder cancer are 73 years of age. So it's more of a diagnosis of elderly Americans. Additionally, bladder cancer seems to be harshest on those that are in the elderly. So it disproportionately is more aggressive in those that are in the elderly. Part of it may be the immune system. Part of it just may be the fact that the bladder has been exposed to toxins for that much longer. A little bit about the invasiveness of bladder cancer. Whenever we see small little tiny tumors in the bladder, we call those TA bladder tumors, and I'll show you some pictures later. Sometimes there's flat lesions. Those are called TIS or CIS or carcinoma in situ. Sometimes the cancer can invade this lamina propria layer. It would be a T1. If it invades the muscle, it would be a T2. If it invades the surrounding fat, it's T3. And if it invades surrounding organs, it's T4. Upper tract tumors. Remember I told you that bladder cancer or urothelial carcinoma isn't just in the bladder. It could actually be in the ureter or actually up in the collecting system of the kidney. Here you actually see this fluffy, velvety stuff located in the ureter. This is urothelial carcinoma of the ureter. Here is an X-ray where we shoot some dye, and you actually see an area where there's no white opacity, and that tends to be associated with bladder cancer up here. And here as well, you can see a tumor located in the right kidney. As far as the stage of bladder cancer, now we've got varying stages, and people are maybe diagnosed with one stage, and they can't really compare their outcomes unless that you really have to compare them with someone with a similar stage. So most bladder cancers are actually localized to that inner layer, and 51% of those patients. 35% of the patients are actually diagnosed with cancer that's still localized to the bladder. So you put those two together, we're talking about 86% of patients are diagnosed where the cancer is either in the inner layer or still contained with the bladder. The rest of it, 7% of the cancers have spread to the lymph nodes, 4% have metastasized to other structures, and 3% we don't have adequate staging for. Now let's look at outcomes. People whereby the cancer is still on that inner layer of the bladder, their 5-year survival rate is 96%. So you get diagnosed with this type of bladder cancer, there's a very good chance that we can beat it, and you're going to live a healthy, long life without any problems. If your cancer is localized to the bladder, there's about a 70% chance that you'll live 5 years from this. So there's a 30% chance of dying of bladder cancer. Once that cancer spreads to the lymph nodes, however, is where the mortality rate significantly increases. So about 1/3 of patients are alive after 5 years if the cancer is spread to the lymph nodes, meaning 2/3 of patients have died. And if it's spread to distant organs, the chance of them surviving 5 years is 5%. So to summarize this, 75% of patients are diagnosed with cancer that's still localized to the inner linings of the bladder or the lamina propria layer. Their chance of dying of bladder cancer is only 15%. Majority of the deaths of bladder cancer are attributed to those that have invaded the muscle or have invaded to the lymph nodes. So this 25% of patients that are diagnosed with bladder cancer comprise 85% of all bladder cancer-related deaths. Okay? Progression. So the reason why we're so aggressive with the way we do things is the fact that about 15 to 25% of patients who have this non-invasive cancer can actually invade into the bladder muscle wall and start spreading to the lymph nodes. And about 20 to 45% of patients who are diagnosed with an invasive cancer will actually have metastatic cancer when we remove the bladder at a later time point. Now, this is what a low-grade bladder tumor looks like. It looks like a sea anemone, or it looks like a little cauliflower. You find a little tiny one right over here. The standard of care for treating this low-grade bladder cancer is cutting out the tumor in its entirety and injecting a little bit of chemotherapy in the bladder to prevent the tumor, the free-floating cancer cells, from reimplanting anywhere else. Okay? These patients don't need too frequent of a cystoscopy. A cystoscopy is where we place a small little scope into the urethra and into the bladder and look around to see if there's any recurrences. These low-grade TA tumors tend to be less aggressive and can be surveyed less frequently. Now we have a high-grade tumor. Now this is one that looks like CIS here. It has a velvety pattern. It's sessile, meaning it's flat. It doesn't have that cauliflower appearance. The standard of care for this is removing the tumor, and if you find out that it's high grade or if it's T1, you make sure that the doctor takes you back to the operating room to go back and cut out some more tissue to make sure there's no residual disease. After all that is done, about 4 weeks after that, we advise that the doctor put BCG into the bladder. And what that is a nurse or a doctor's office slips a small little catheter into the bladder, and they squirt a small amount of BCG. And what this does is it ramps up the immune system in the bladder to kill all the cancer cells. Now, most people get 6 weeks of BCG, so they come in once a week for 6 weeks, and they get this treatment. But what's important is you don't stop there. Patients should get 3 installations, so once a week for 3 weeks, every 6 months for up to 3 years. So in total, it adds up to about 27 installations in a 3-year period of time. These patients, since they have an aggressive tumor, even though it hasn't invaded yet, we advise that they undergo frequent cystoscopy and cytology. And cytology just means we're sending the urine off for a urine test, and we have specialists in pathology who look under the microscope to see if there's any cancer cells there. We also recommend that they get a CT scan every 1 to 2 years. I tend to get CT scan in about 18 months for patients that are on average, but for patients who I'm afraid may have invasive disease, I get it every year. Now, the thing with bladder cancer, high-grade non-muscle invasive bladder cancer, is that they have a high propensity of recurring. So if they do recur, the doctor may try to put another round of BCG in the bladder, another 6 installations, or they may want to put in interferon, which also ramps up the immune system. They might want to try one of these other chemotherapeutics, which is gemcitabine or valrubicin. Most doctors, however, should advise their patients that radical cystectomy is still something they should strongly consider if their cancer keeps coming back despite BCG therapy. So a radical cystectomy shouldn't be taken off the shelf. It is something that we strongly advise for patients who have recurrent high-grade bladder cancer. However, the treatment type depends on the grade. Is it a recurrent high-grade TA, or is it a recurrent high-grade T1? T1 would be more aggressive than TA, and so someone for high-grade T1 that keeps recurring, I'd probably advise them to undergo a cystectomy. High-grade TA, I'm willing to try some of these other agents for a while. And also the timing. So if the cancer tends to come back much sooner, it tends to portend a worse prognosis, whereas one that goes cancer-free for a year or 2 years and it comes back, those patients tend to do well. Now, how about if the cancer is invasive? What do we do for that? Currently, we advise that patients have their bladder excised, so the entire bladder and the surrounding organs are removed. We sometimes advise that they get chemotherapy before or after surgery. And once we take the bladder out, we lose that storage capacity. So we have to find a way to divert the urine. And we can do this by either building a new bladder made out of intestines or building a new bladder that the patient can catheterize off to the side. Or we would create an ileal conduit where urine just drains into a bag constantly. Also, we also advise patients may benefit from radiation therapy along with chemotherapy. Now, this requires that they get radiation to the bladder 5 days a week for about 6 to 8 weeks, and they also get some chemotherapy associated with it. Now, chemotherapy in combination with either surgery or radiation can be before or after, and it can last anywhere from 6 weeks to 6 months. It depends on the type of protocol that you're on. Now, if the cancer is already spread to other places, there really is no benefit in surgery or radiation unless it's reserved for those where we're trying to treat pain or local symptoms from a tumor that's invading into surrounding structures. So for those patients where the cancer is spread to the liver or to the lungs or to the bone, systemic chemotherapy is the primary treatment. And the types of chemotherapy you may get is MVAC, which stands for methotrexate, V is vinblastine, A is adriamycin, and C is cisplatin, or one of these other agents. Sometimes they're in combination, and sometimes they're single agents that we give. Now, we're going to talk about the upper tract as well. So the upper tract cancers are ones where we actually find tumors in the collecting system of either the kidney or in the ureter. And the treatment for those non-invasive upper tract tumors is we slip a small scope, and using a laser fiber that has the width of a hair follicle, we can actually ablate these small tumors, or we can grasp these small tumors with a small basket that's a little bit larger than the size of a hair follicle. We can grab these tumors and pluck them out, and we can prevent the kidney from being removed. We also advise that chemotherapy be instilled up here to prevent these free-floating cancer cells from reimplanting or from recurring. The way we follow these patients is we recommend that we look up the kidneys frequently and actually get CT scans more frequently. Now, what if the cancer is invasive? The upper tract cancer is invasive. And for that, we would advise that the patient have the entire kidney and the ureter down to the level of the bladder be entirely removed. Chemotherapy should be considered in treating patients with an invasive upper tract cancer. I tend to like to give it before I remove the kidney because they have two kidneys, and chemotherapy is better tolerated when it's given to patients with two kidneys than with one kidney. Now, let's talk about some of the challenges we've seen. Now, we here at UCLA have shown that compliance with some of these measures have not been up to par. Now, we know that intravesical chemotherapy, when patients have low-grade bladder cancer, we instill a little bit of chemotherapy at the time of resecting the tumor to prevent those cancer cells from implanting. We know that it can cut down the risk of recurrence by about 35%. However, only 5% of patients ever get it. And so we asked physicians and we asked them why they weren't using it. And some of it is there's chemotherapy shortage across the United States and they may not be accessible. Some of it is they can't get it into the operating room where they're seeing and resecting the tumor. Sometimes if the surgeon cuts too deep into the bladder wall, the instillation chemotherapy isn't recommended because it can actually extravasate around the bladder and can cause some serious side effects. And lastly, the chemotherapy is not benign. Putting chemotherapy in the bladder, sure, your hair doesn't fall off and you don't have any systemic side effects, but it can actually irritate the bladder and may cause you to have a significant amount of dysuria or pain with urination or frequency, meaning going to the bathroom frequently during the day or night. We also found that the number of cystoscopies we do in the United States isn't up to par as well. We have a hard time bringing patients back in every 3 months and looking in their bladder. Part of it is it's uncomfortable, and patients are increased likely to get urinary tract infections. So what are some of the things that we're doing at UCLA? First is with the use of newer technologies such as blue light cystoscopy. Here you don't really see anything. This doesn't look like anything particular. But with the blue light, you can actually see these tumors much easier. And if that's the case, you're able to see the tumor, biopsy it, and send it off to the pathologist or ablate it entirely. So one of the trials that we're going to be carrying out here is we're going to randomize patients to either get blue light cystoscopy, and then if we find that they have a low-grade tumor that's TA and that's that, we would recommend that they get an annual cystoscopy just once a year versus standard of care for the European Association of Urologists, whereby you get a white light cystoscopy and you get that at 3, and if you found to have a low-grade TA tumors, you would get another cystoscopy at 3 months, 9 months, and then annually thereafter. And some of the things we're going to be looking at is recurrence and progression rates, which we anticipate would be low, but still there. And then have patients fill out a quality of life questionnaire. Patients are much happier with their urologist when he's doing a cystoscopy less frequently as compared to more frequently for low-grade tumors. Also cost. Doing a cystoscopy every 3 months may be burdensome from a financial standpoint to both the patient and the healthcare system. Next, intravesical instillation of chemotherapy. Remember I was telling you about putting chemotherapy inside the bladder to prevent the floating cells from reimplanting? Well, one of the things we're doing here is that there were studies that have been done outside the United States where they showed that if you actually leave a catheter for a few hours and just run saline water, salt water through the bladder, you can prevent those cells from reimplanting. And you actually may have a response rate to that's just as good as the chemotherapy without the toxicity, without the chemotherapy shortage, without the access to the chemotherapy. And so one of the trials we're doing here is we're going to randomize patients to either intravesical chemotherapy, mitomycin C, versus continuous bladder irrigation. And then some of the things we're going to be looking at is recurrence and progression rates, but also quality of life. I think patients are going to like this continuous bladder irrigation. However, the standard of care is really still intravesical chemotherapy. I think continuous bladder irrigation is likely to have some benefit there. Now, how about for high-grade cancers? Well, we know that we recommended BCG installations for patients with high-grade bladder cancer to prevent the cancer from recurring. Remember I was talking to you about after high-grade non-muscle invasive bladder cancer is diagnosed that the physician brings you back into the office every week for 6 weeks and then every 6 months for 3-week installations. We found that only 36% of patients got even a single dose. That means 2/3 of patients don't get anything. And only 2% of patients got all 27 installations of BCG. Because of that, the recurrence rates are really high for high-grade non-muscle invasive bladder cancer. We've shown that the recurrence rates across the country for this type of cancer is 75%. The chance that this becomes invasive or metastasizes or kills a patient is 33%. The chance that it can kill a patient is about 12%. So this is a cancer that is curable, but is slipping under our nose here. Now, what happens when these cancers recur? What are patients and what are doctors doing? When the cancer recurs 1, 2, 3, or 4 times, we're finding that still only 30% of patients are getting anything done for it. So 7% of patients are getting their bladders removed, 18% of patients are getting radiation therapy, and then 7% of patients are getting systemic chemotherapy. What that translates into is 70% of patients are getting nothing for their recurrent high-grade bladder cancer. Part of that could be that doctors don't feel comfortable doing these types of operations, but I think another component is that patients don't want to suffer the life-altering effects of having the entire bladder removed and having to wear a urine bag for the rest of their life. So, like I said, radical cystectomy may be too life-altering for many patients. And then radiation and chemotherapy isn't all that effective if you have that CIS, which is that flat, velvety lesion in the bladder. Now, we've also shown that patients who recur recur multiple times are 2 to 3 times more likely to die of bladder cancer. So having multiple recurrences is a bad prognostic biomarker. Now, if they aren't treated aggressively, that bodes poorly for survival from bladder cancer. So what are we doing about it here? Well, we have approval to do this, a clinical trial where we're using a genetically engineered virus called CG0070. It's an oncolytic virus that's actually instilled into the bladder. And what we do is we do 6 installations of this virus. For every 3 patients, 2 patients will get the virus and 1 patient will get standard of care, some other chemotherapeutic that the doctor personally has seen prior success with. And so it's a randomization of 2 to 1. It's not 50-50. There's a 67% chance you're going to be randomized to the virus arm, and there's a 33% chance you're going to be randomized to the standard of care arm. And we're going to be looking at complete response rate. So the way this works is that we slip a catheter into the bladder. We instill a soap that takes out the coating of the bladder, and then we put the virus in there every week for 6 weeks, and then we're going to look at response rates. The phase 1 study from this virus has been extremely promising. So patients that have received 6 weekly installations, 78% of them have had a complete response. If they have a genetic mutation that this virus actually targets, their response rate's 100%. So this is actually a very promising virus that has been shown to help patients with recurrent high-grade CIS that has failed BCG therapy. So this is a brand new clinical trial. We're going to be the first ones in the country to enroll. We actually have a patient enrolling in this soon. How about if the cancer is invasive? What do we do for that? Well, if you actually look at the literature, we find that of those that have invasive bladder cancer, only 21% undergo removal of the bladder. 28% have radiation therapy or chemotherapy, and another 51% of patients don't get anything. And here at UCLA, we do robotic radical cystectomy, small incisions. Patients go home in 4 or 5 days, and we can build them a brand new bladder. We do this all the time, but patients still tend to have a preference of having their own native bladders. They don't want to have it removed. So what do we do for those patients? Well, we can give them radiation therapy. The problem is that sometimes the radiation therapy isn't that effective. In fact, in the best of hands, we find that of all patients that have had radiation therapy, 29% will still not respond to radiation, and they're going to have to undergo removal of the bladder I'd say in a non-ideal setting, meaning they've had prior radiation, prior chemo, and then the surgeon would have to go in there and remove the bladder after that. Also, the 29% cystectomy rate, I think, is attributed to the fact that the bladder may not be all that well visualized, or the tumor may not be well visualized, because the bladder isn't a structure like a breast where it's not going to move. The bladder one day can be full, the next day is empty, it can be in the abdomen, the next day it's down in the pelvis. So it's hard to target, and it's hard to see these bladder tumors times. It's so deep into the pelvis. So what are we doing about that? Well, we were the first in the country to actually first in the world to use this brand new gel, where this gel is located here and it's compared to a titanium clip. So you look at this, you can see this gel at 1 week, at 6 weeks, at 12 weeks, and at 32 weeks. Now remember when I told you about radiation therapy tends to last anywhere from 6 to 8 weeks? Well, by the time you're finished with your radiation therapy, this starts to dissolve. But during that time frame, the actual radiation oncologist, the physician who's going to be delivering radiation to the bladder, can actually see where the tumor is. So we actually go in there as a urologist, as a surgeon, at the time that your bladder tumor is resected, we put this small little tiny needle into the bladder and inject this gel in the area where the cancer is, and we also mark out the borders of the bladder. And what that does is it allows the radiation oncologist to actually deliver radiation to the area of the bladder and the cancer and avoid hitting the uterus or the prostate or some of these other organs. Here, if we haven't had this, if we hadn't had these gel implants, radiation oncologists may have been hitting the uterus, which may be associated with side effects such as vaginal bleeding or actually secondary malignancies in some of these other sites. How about chemotherapy? We know that the use of chemotherapy for invasive bladder cancer is not where we'd like it. In fact, part of it is attributed to the urologist. They oftentimes don't refer patients to medical oncologists. So 20% of patients with stage 2 are referred to a medical oncologist, 25% of stage 3 patients are referred to a medical oncologist, and 36% of patients with cancer that have spread to other organs are referred to medical oncologists. Now, over the years, that's improved. So we're doing a better job. So the rate has gone from about 18% up to 30%. Now, that doesn't mean all 30% of patients are going to get chemotherapy. We find that only half of those are getting chemotherapy. So even though they're referred for chemotherapy, only about half are getting it. So why aren't patients getting chemotherapy? Now, part of it is that chemotherapy may not be all that effective for some of these cancers. Unfortunately, we can't predict who's going to respond and who's not. That's what we've been dealing with for many years. We give patients chemotherapy, and we hope that it actually improves survival and it actually can shrink the cancer so that the surgeon can go back in there and cut it out. The problem is that we're exposing a lot of patients to significant amount of side effects: hair loss, numbness in the fingers, loss of kidney function, and this really may outweigh the benefits, especially if the cancer is localized to the bladder and excision or radical cystectomy can actually cure the patient, or if the cancer is spread to the organs to other places and it's not going to respond to chemotherapy anyway, so why expose patients to that? So those are some of the challenges we have. So in collaboration with scientists at Lawrence Livermore and UC Davis, they've actually developed a new clinical trial that we'll be opening up very soon that actually has a carbon-14. Now, carbon-14 is how we date fossils and material on Earth. And this radio-labeled carbon is put on a small dose of chemotherapy. Carboplatin is a chemotherapy. Now, patients are given an itty-bitty dose, only 1% dose of carboplatin. And then we take them the next day to the operating room and take a small biopsy of where the tumor is. And we look at the amount of carbon-14 that's in the DNA, in the genes, and based on its uptake, we'll be able to predict whether they're going to respond to this chemotherapy or not. Now, we're starting off with this radio-labeled carboplatin 14, But in the future, we're going to be opening this up to other chemotherapeutics as well. So this can really help patients determine whether they're going to be responsive to chemotherapy or not before they get chemotherapy. Now we're going to talk about the upper tracts. Now, if I ask you which patient is more likely to have their kidney removed. Now, here is the right kidney. That's the left kidney. That's the liver. Here you see this abnormal tumor, just where the arrow is pointing to, this large circular mass. It's about 5 centimeters. And this patient, a separate patient, has a small little tumor. It's about 1 centimeter. It's right in the middle there. Okay? If I ask you which patient is more likely to have their entire kidney and ureter removed, the logical answer would be this one. But that's not true. Actually, these patients are much more likely to have their entire kidney and ureter removed. These patients, we're able to preserve their kidney function and only cut out the tumor and leave the rest of the kidney behind. We could do this robotically with minimal convalescence. So what have we found? Well, we've looked at series in the United States across the country. And out of 15,000 patients that have been diagnosed with these small little tiny tumors, 59% of them are diagnosed with these small little tiny tumors. However, nearly 80% still have their entire kidney and ureter removed. Now, if we're looking at low-grade, non-invasive tumors, these are really non-aggressive tumors. Still, 75% of the patients have their kidney removed, and an additional 16% have their ureters removed. So only 9% of patients are being treated endoscopically. And guess what? There's really no difference in survival here. Well, why are physicians doing that? Why aren't physicians endoscopically treating these tumors and then putting chemotherapy up in the collecting system to improve survival? Well, what we're finding is that here, this is a case we did where we instilled a dye up this right kidney, and here you can actually see a tumor, and here you're actually seeing tumors all along the ureter. Now, this patient is not a candidate for nephron-sparing surgery or kidney-sparing surgery. This patient is a candidate for removal of the entire kidney and ureter. But this really elucidates a good point. We simply squirted dye up this kidney. Okay? 30 seconds later, we took an X-ray. Notice all the dye is pretty much gone in the ureter, and a little bit of it is still left in the right kidney. Okay? What does that mean? Well, that means that if we squirt chemotherapy up there, it's probably going to only sit there for a minute or 2 minutes or 5 minutes or 10 minutes at most, unless, of course, the kidney's blocked, right? So chemotherapy works by exposing the agent to the tumor for a prolonged period of time. Well, it's hard to do that with the kidney when it's actually being excreted at such a quick rate. So in collaboration with an international company, we have devised a clinical trial where there's a gel that in room temperature is liquid, and as soon as it hits body temperature, it turns solid, and it takes the shape of whatever structure you put it in. So what we can do, and what we've done in preclinical studies, is we've actually have this gel and mix it with a chemotherapy and squirt it up into the kidney. Now here, this is time 0. This is before installation. And this is where we've actually instilled it. Now, we're not talking about seconds, and we're not talking about minutes. We're talking about hours. So 1 hour, 2 hour, 3 hour, 4 hour, 5 hour, and 6 hours. This gel with the chemotherapy is still up there having its local effect. It's actually eating away at the tumor and preventing the cancers from coming back or progressing. And the patient will slowly excrete this gel and chemotherapy and urinate it out over a longer period of time instead of over seconds to minutes. And so we've had excellent safety profile. We found that the chemotherapy isn't being absorbed into the bloodstream. And we found that this gel isn't blocking the kidney. And so the kidney function works normally. And so we're going to be opening up a clinical trial for patients with upper tract cancers. These are for patients with non-invasive upper tract cancers. And patients are going to be randomized to either laser ablation. We're going to go up there with the laser scope and ablate the tumor and maybe squirt some chemotherapy in the standard fashion, versus going up there with a laser, ablating the tumor, and then putting multiple doses of this gel with chemotherapy over weeks. So twice a week for 3 weeks, so patients get 6 installations or 8 installations, which is over 4 weeks. And then we're going to look at how feasible is this, how safe is it, how is the durability of this agent and the ablative effect. And we're going to be looking at response rates, complete response rates at 3 months and eventually at a year. So this is a really, really hot topic in upper tract cancers. And that's the end of my talk today. If you have any questions about any of the clinical trials, feel free to call us, make an appointment. Just specify which clinical trial you're interested in, or just shoot me an email. Happy to respond to you and help direct you further. Okay. Again, if you're on the webinar, and if you have questions, just feel free to ask us questions on hashtag UCLAMDChat. Thank you. What are some of the common risk factors for bladder cancer? We talked about this earlier, but risk factors for bladder cancer include tobacco use, exposure to dyes or solvents. It can also be the type of workplace you're in, so being exposed to some of the organic solvents, hairdressers, mechanics, machinists, truck drivers, those also increase your risk of getting bladder cancer. Of course, the older you are, the more likely that you'll develop bladder cancer. So a rule of thumb is 1 in 3 or 1 in 4, so 3 or 4% of men will develop bladder cancer sometime in their lifetime, and about 1% of women will develop bladder cancer sometime in their lifetime. Men more likely, women less likely. The older you are, the more likely. And genetics. If you have a father, mother, brother, sister who has bladder cancer, you're more likely to get bladder cancer. Next question. My husband has low-grade bladder cancer. Can he participate in the clinical trial using the genetically engineered virus? Good question. No. The genetically engineered virus, the Oncolytic CG0070 virus, is strictly for patients who have high-grade BCG refractory CIS. So low-grade cancers don't qualify for that. Next question. I have CIS bladder cancer that has failed multiple doses of BCG. Will I necessarily get the oncolytic virus if I participate? No, but there is a 2/3 chance. There's a 66.6% chance that you're going to get the oncolytic virus. But there's a 33% chance you're going to get standard of care. So we're going to use a drug that's actually been shown to have some benefit in patients who have BCG failures. But this also raises another point. The company's actually also allowed to use this for compassionate use. So we would be able to give you the virus after the 3-month window as a compassionate measure, not necessarily as a part of the trial. What are some of the common side effects of the clinical trial with the oncolytic virus? Most commonly, a little bit of pain with urination and urinary frequency, going to the bathroom frequently. And the reason that is we're basically removing the inner lining of the bladder and putting the virus to allow it to get in. But over time, that gets better. And obviously, we have treatments to help. We have pain medication. We have certain types of medications that help alleviate some of those symptoms you're having. Next question. My father has upper tract cancer of the kidney and bladder cancer. Can he still participate in the hydrogel clinical trial? Absolutely. Having cancer in the bladder doesn't preclude you from getting the gel in the kidney. So he can absolutely participate. Next, what are some of the side effects of the gel that is inserted in the bladder for radiation therapy? Really not much different than just going through radiation. We're putting really small amounts of gel inside the bladder lining to allow the radiation oncologist to target the radiation to the area of the cancer. So really not much side effects. If any, you may have some urinary frequency or urgency, meaning you have to go to the bathroom frequently, and when you got to go, you really got to go. How long will the gel last before it is dissolved? And will the cancer come back if this happens? Like I said, the gel will last a few weeks, about 3 months before it's completely dissolves. And no, again, the gel has no therapeutic benefit. It's the radiation that has the therapeutic benefit. What the gel does is just the GPS system for the radiation oncologist, so they know where the cancer is, they know where the bladder is, and they're not just shooting radiation blindly. They're actually targeting the area where the cancer is and where the bladder is. Will the patients who choose to participate in the microdosing study, this is the carboplatin, the carbon-14 study, have a choice to receive chemotherapy if their cancer is found to be resistant to the test dose? Well, if they have metastatic bladder cancer, they really don't have many options. I mean, I think that they probably would need chemotherapy irrespective. And we're not going to be able to let patients know immediately after we do the biopsy to see whether they're going to be sensitive or not. We usually wait to see whether they've responded or not to know whether what the after effects are. So I still think if you have metastatic bladder cancer, you're still going to need chemotherapy. What this does is it adds more information, so that it helps guide us as far as future care. How much radiation will I be exposed to from the carbon-14 in the microdosing study? That's a good question. So carbon-14 elicits a small amount of radiation. The amount of radiation that you get from that is approximately 1 chest X-ray. For patients that have bladder cancer, we're not talking about 1 X-ray. We're talking about CAT scans, and CAT scans are about 100 X-rays. So not much difference. Who do I contact to participate in the clinical trial? Again, I'll put that up there. You can feel free to contact me by email, but you can also call to make an appointment to talk about some of the clinical trials. Oh, we got some more questions. Wow, busy. Are there any new screening methods for bladder cancer? In the United States, the way we screen patients with bladder cancer is a urine test, and so go to your primary care physician. Usually on an annual basis, your primary care doctor will get a urine test. If you're high risk, meaning you're over 50, you're a smoker, been exposed to some of these dyes, I would advise that you get screened more frequently, but there are other types of urine tests, immunohistochemical staining test, fluorescence in situ hybridization. Some of these new urine tests are actually a little more sensitive than just a urine analysis. So if you're high risk, definitely may benefit from some of these tests. If I have my kidney bladders removed, how will I go to the bathroom? Well, so I think this person may have both an upper tract urothelial carcinoma and a bladder cancer. If you have an upper tract tumor, that kidney, that ureter, and the bladder have to be removed. You can still go to the bathroom because you have another kidney, and most people can do just fine with just one kidney. We can take a piece of intestines, fold it up into a new bladder, and hook it down to the urethra, and you can try to urinate normally. It's not exactly normal. You have to kind of bear down to get the urine out. Or we bring it up to the skin, where you slip a catheter in 4 or 5 times a day to empty the pouch. Or we give you a urine conduit, an ileal conduit, where it applies into an external appliance. So you still get to go to the bathroom. Unless, of course, you have both kidneys involved. In that case, you probably would need to be on dialysis. Out of the clinical trials that you mentioned, which are the most promising? I'm actually optimistic about all of them. I think we can't just come up with one clinical trial that is most promising. I think they're all specific. I mean, patients with bladder cancer, it's not just one face or one figure. Bladder cancer comes in various flavors and various forms, and we're trying to develop a clinical trial for each individual patient. Depending upon what type of cancer you have is probably the most promising for you. So each person is a little different. Any more questions? Okay, I think that concludes our webinar. If you have questions, again, put this up here. Send me an email or call our office. All right, bye-bye.